everyone, my name is Hassan and I'm a third-year pharmacy student enrolled at Wayne State University School of Pharmacy. Today, my presentation is going to be about the initiation of enteral sedation in patients requiring mechanical ventilation. The objectives of the study are to determine what are the IV sedative and analgesic requirements before and after enteral sedation with diazepam, oxycodone, methadone, or clonidine, and then perform subgroup analysis on each drug class. To provide a little background of what prompted the study, the recent COVID-19 pandemic has taken the U.S. healthcare system by storm. To date, there are 6,786,352 total cases in the United States, with 283,358 just from the last 7 days. These statistics are taken from the CDC data tracker and are accurate as of September 21st at 12:16 p.m. Patients with COVID-19 who experience severe symptoms may be admitted into an ICU and require mechanical ventilation. When patients are placed on mechanical ventilation, they require sedation in order to reduce the physiological stress of respiratory failure and improve the tolerance of invasive life support. Most institutions will turn to IV sedatives in order to provide the sedation. However, during the initial peak of the pandemic, many institutions did not have enough IV sedatives supplied for all of their patients and ran out of stock. To ensure that we are able to preserve our supply of intravenous agents for future patients in a time when drug supply remains unknown, it has become imperative for us to consider alternative approaches to sedation. Use of enteral sedation to down-titrate intravenous infusion rates is one possible approach, although minimal data exists to guide the strategy. Our study was a single-center retrospective observational study that wanted to compare a patient's IV sedative requirement before and after initiation of concurrent enteral sedation. The first date and time that the patient had received an enteral sedative would be considered the initiation date. The patient was followed 2 days before and 5 days after receiving enteral sedation. Essentially, we were comparing the patient's IV sedative requirement before initiation and comparing it with their IV sedative requirement after initiation. 441 patients were originally screened, but 28 received concurrent paralytics, 229 were not on mechanical ventilation for greater than 24 hours, and 132 did not receive at least 12 hours of IV sedation prior to being switched to a combination of oral and intravenous sedation. After these three exclusion criteria were applied, 52 patients remained in the study. Just taking a look at some of the baseline characteristics of the study, the average age was about 60 years old, roughly 63% of the 52 patients were male. 37 of the 52 patients tested positive for COVID-19, and the remaining 15 were negative. The average BMI was 32, the length of stay was 15.7, the average duration of mechanical ventilation was 9.78 days, and 34 patients in the study had AKI. Before getting into the statistical test, I wanted to talk a little bit about the data we created in order to determine if IV sedative use had went down. We created a new variable called RELSED, which was representing the IV sedative amount that patients received on a particular day compared to the original amount that they had received. Afterwards, the Pearson correlation coefficient and two-tailed significance were both calculated. In order to ensure enough patients were enrolled, we used a smaller effect size of 0.4 with a two-sided alpha of 0.05 and a power of 80%. Taking a look at the results generated, it seems that there was a weak negative correlation between RELSED and time with a Pearson correlation coefficient of negative 0.292. This tells us that as time went on, the patients had received less IV sedative. However, as we will get into with the next data points, this may not have been due to the enteral sedatives received. For the RELSED versus clonidine dose, we see a Pearson correlation coefficient of 0.067, showing essentially no correlation with IV sedative requirement. For RELSED versus opioids, the Pearson correlation coefficient of negative 0.126 tells us that there was a very weak negative correlation between IV sedative requirements and enteral opioids. Lastly, for RELSED versus benzodiazepine dose, there was a very weak positive correlation from the Pearson correlation coefficient of 0.148, indicating that patients that received oral benzodiazepines also required more IV sedatives. Having looked at the results, the research group concluded that there are no large effects on RELSED use from the use of enteral opioids. The data from this study does not support the hypothesis that enteral sedatives can be used to reduce the amount of IV sedatives used in a clinical setting. However, we believe that more research needs to be done in the area in order to draw a full conclusion. Some limitations of the study that the research group is thinking about changing in order to get a fuller picture of the full effect of enteral sedatives would be looking at the patient's PaO2/FiO2 data to determine the patient's current status while on the ventilator. This change will clarify if the negative correlation between RELSED and time was due to other factors other than the patient's condition becoming better. Secondly, we wanted to see if we had a true control group from a previous period of time and compare the correlation between RELSED and time in both our study group and the control group. Lastly, I'd like to take the time to acknowledge the other authors in the study and all of the hard work they've contributed. I'd also like to thank the Eugene Applebaum College of Pharmacy and Health Sciences for hosting the research day, as well as the judges and attendees that make the event possible.